look at all that money, yeah, the money that they spend. Take another look now and take some time for hemp. I don't cut trees for paper, cause it hurts the environment. Stop deforestation, yeah, it's time for hemp. Oh, an acre of hemp makes 20 barrels of oil. No need for pesticides to poison all our soil. People got no food, they got no clothes, they got no rest. Well, right now it's time for hemp.
Thank you for taking time for hemp. I'm your host, Casper Leach. You are listening to the live broadcast of Time for Hemp all around the world on AmericanFreedomRadio.com and AM/FM stations all across America. We are starting a very special presentation. This is the second conference in 5, and this is the first of 2 hours in that second conference. The first conference, we focused on industrial hemp, and this particular conference is focused on medical marijuana, the need to heal the sick all around the world with this wonderful plant. We've waited a long time to be given the opportunity to speak before members of our governing bodies globally, including the UN, and we have not been invited to sit down and present the need to end prohibition and why it is so important that this plant be made available for a variety of reasons, whether it be for industrial or for medical. And because of that, Time for Hemp has organized this presentation. Today's presentation is being moderated by Lynn Mathre and Byrne, founders of Patients Out of Time. And as we bring on today's panelists, they will be introduced by our moderators. And this conversation will be presented in such a way that it is nothing but information that is valuable to share. With that said, I'm going to end my attitude to this conversation and pass this conversation to Mary Lynn and Al. Mary Lynn, Al, thank you for taking Time for Hemp.
Well, as always, we're glad to be here, Casper. I want to thank the guests that I know are online right now, Dr. Mechoulam and Franjo Grotenhermen. Patients Out of Time is proud to be part of this presentation. I will be really the moderator today. Mary Lynn is actually going to make a presentation later in the afternoon. Our first speaker today is a doctor from San Francisco, a medical doctor named Donald Abrams. He is an old friend and supporter of Patients Out of Time. He is the chief of hematology oncology at San Francisco General Hospital. He is also a professor of clinical medicine at the University of California in San Francisco. Dr. Abrams, are you there, sir?
Yes, I am. Good morning, Al.
Good morning, Donald. Very nice to hear your voice. We want to get right to business here. The folks that are listening across the country and around the world are interested in real science, not professional science or political. So we're here to give them real science. And I know that your science has been frustrated by the United States government. I wonder if you could tell the folks about trying to do a positive cannabis study in the United States, the difficulties.
Thanks, Al. So the only legal source of cannabis to study in human research is the National Institute on Drug Abuse, NIDA. And NIDA actually has a congressional mandate to only study substances of abuse as substances of abuse. So when I started way back in 1992 petitioning NIDA for cannabis to do research in patients with HIV and the wasting syndrome, I quickly or not so quickly learned this and realized that my request for cannabis and for funds to fund the research from NIDA could never be granted. Since that time, however, NIDA has made cannabis available for studies to look at its medical benefits as long as they're not funding it. That's okay with their congressional mandate because they're not funding the studies, but being the only legal source of cannabis in the country to study, if somebody does want to look at, for example, the effectiveness of cannabis in treating a pain syndrome, if they can get funded elsewhere, NIDA does make their cannabis available. So in truth, the situation has changed quite a bit since I began trying to do cannabis research 20 years ago, such that, for example, now we're hopefully going to be funded to do a study of cannabis in sickle cell patients. The funding comes from another branch of the government. Currently it's sequestered. Hopefully it will soon be released. And we're working with NIDA to obtain the cannabis, and they're very helpful. In fact, in this particular study, we're interested in looking at a blend of cannabis that has both THC, tetrahydrocannabinol, the main psychoactive ingredient, and CBD, or cannabidiol, which is an anti-inflammatory analgesic cannabinoid that's not present in all strains of cannabis. So NIDA is actually being very helpful in the current situation. But the real truth is that there is a congressional mandate, and in this country where we're fighting a war on drugs, it's difficult to study substances which are scheduled as Schedule 1, meaning high potential for abuse and no accepted medical use. It's difficult to study Schedule 1 substances for their medical benefit.
Well, Doctor, where is this cannabis that you hope to use to get your study going? Where is it coming from? Is it coming from the federal pot farm down there in Mississippi?
Yeah, Mahmoud El-Souleh has the farm in Mississippi where he grows cannabis and makes the cannabis available to the National Institute on Drug Abuse for their studies and for supplying other investigators. That is, again, the only legal source of cannabis in the country. And, people have concerns about that cannabis, but in the research I've done, it's shown that cannabis has medical effects. In fact, it seemed to work in treating nerve pain in patients with HIV. It seemed to be able to increase pain relief in patients with chronic pain taking long-acting opiates. So the quality of that cannabis might not be as high grade, for example, or as fresh as cannabis that people obtain in dispensaries if they live in a state where medical cannabis is allowed, but it still works. So, if that's all we can use, then we need to use it. And again, Dr. El-Souleh and NIDA have been responsive to the needs of the investigators, and as I mentioned, we will be getting a strain that's a mixed CBD and THC, and I also understand that Dr. El-Souleh has made a cannabis oil preparation, which I'd also be interested in studying.
Now, when you say Dr. El-Souleh is doing this, is he doing this for personal gain, or is this part of his contract with the government? Who owns this oil? Why don't the federal patients have access to that?
I don't have the answers to those questions, Al. Sorry.
Yeah. Okay. Well, it's kind of curious because my experience with the federal patients and the quality of the cannabis that is produced in Mississippi is that it's awful. It's old, as you say. I've seen it issued to the patients as old as 10 years. And that seems to me, I grant you have to do what you have to do, but it seems like an unfavorable quality of plant to test.
We don't have people smoking it in the pre-rolled cigarettes anymore because it is a bit harsh, and mainly we're looking at vaporization as a smokeless delivery system, so that's how we're processing the cannabis for patients to use.
Okay. Well, let me shift you to another subject that I know you're very familiar with and people need to know about is the use of cannabis with cancer. Could you expound on that a little bit?
Yeah, it's when I was training to be a cancer specialist, I hate to date myself, but it was in the 1970s. And in the 1970s, that was a whole different time in the world of cannabis. Jimmy Carter was president. There was much more widespread use of cannabis amongst the American public, and in my training to be a cancer specialist, even in 1970s, there were a few cancers that we could cure, and interestingly, they were cancers that mainly affected young people, Hodgkin's disease, testicular cancer, and also interestingly, the chemotherapy regimens that we used then are pretty much what we use now, and they're very potent, and very effective, but they also cause a lot of nausea. And back in the 70s, we really didn't have very effective anti-nausea medications like we do now for chemotherapy. And so many patients, young people with these cancers that we could cure with aggressive chemotherapy, said, you know what, your prescription anti-emetics or anti-nausea drugs are okay, but smoking cannabis works much better. And so that was the first clue that, cannabis had some potential for chemotherapy-induced nausea and vomiting. And, again, it really has not been studied, the whole plant, but dronabinol, which is the synthetic version of delta-9 THC, was ultimately licensed and approved as a treatment for nausea and vomiting back in 1986. Dronabinol, again, is just one chemical in the plant. The plant has 400 other chemicals, 70 other cannabinoids like THC, and also other chemicals in the plant that have medical benefits. So as a cancer doctor now for the last 30 years, growing up in the 70s, just a day doesn't go by when I don't see a cancer patient who has nausea, vomiting, loss of appetite, pain, depression, and insomnia. And most of my oncology colleagues will then take out their prescription pad and start writing prescriptions for 5 or 6 different medications, all of which may interact with each other or with the chemotherapy that the patient is taking. And I can just recommend, because I'm fortunate to live in California, that patients try cannabis, because cannabis is one medicine that can speak to all of those different symptoms. And it's also a medicine that many of my patients can grow themselves. And if you have cancer and part of you is dying, or you feel that you're dying, the ability to bring life out of the ground is something that's very rewarding. And if you're growing your own medicine, that's very empowering. So I see patients every day, as I say, for whom I recommend cannabis, and who tell me that cannabis, for example, was the only thing that decreased their nausea and vomiting, despite all of the modern anti-nausea drugs that we have to go along with chemotherapy. The only thing that allowed them to play with their kids. And on the other hand, I see patients who are near death, who are put on high doses of opiates and get totally zonked and can't communicate with their family anymore. And they find that if they wean down from their opiates and use cannabis instead, that their pain is relatively well controlled, and they are much more capable of being in the moment and sharing the last weeks, days, months of their life with their family and loved ones. So I think it's a very potent medicine, and I often find myself opposing on a panel or a debate people that are in the drug abuse community. And I always say it's sort of like the blind men and the elephant, if people remember that analogy. I mean, I'm a cancer doctor. I'm not seeing the small percentage of patients who have cannabis dependency problems that my colleagues in substance abuse see. So where they see it as this horrible, agent, for me, it's a lifesaver for many patients.
Yes, and of course, Patients Out of Time is named that way. We are representing patients who are out of time, and we think cannabis is a lifesaver. It has saved many of our lives, and it will continue to do so. And people will use it in this country in legal states and in illegal states because it's smart to do so. But Dorothy, could you just go over a little bit more about how cannabis can supplant or replace other medicines? And please define synthetic cannabis. I've been told that people think it's some sort of real whole plant synthesis, and it's really a petroleum-based product, is it not?
Which one? Dronabinol?
The synthetic cannabis, the Marinol, the Dronabinol, is not that a petroleum-based product?
And the pharmaceutical companies can synthesize molecules, and delta-9 THC is a 21 carbon. I believe that they are synthesizing the delta-9 THC and putting it in sesame oil as a medicine. But, there are other cannabis medicines as well that are out there and available. Sativex is an under-the-tongue spray, which is an extract of the whole plant, which is available in Canada and many European countries for treatment of spasm, for example, from multiple sclerosis. But in answer to your question, yes, again, as I said, my patients have nausea and vomiting, weight loss. So nausea and vomiting, we have a lot of antiemetics. But again, for some patients, even the most powerful of the anti-nausea drugs that we give with chemotherapy don't work for them, and they do report that cannabis does. I believe Melissa Etheridge came out nationally and said she could not have completed her chemotherapy for her breast cancer if it had not been for the beneficial effects of cannabis. There aren't too many medications that we have that increase appetite. And in fact, none of the prescription anti-nausea medicines we have increase appetite. Cannabis increases appetite. So here you have something that decreases nausea and increases appetite. So you could perhaps decrease some of the anti-nausea prescriptions, which in and of themselves have some side effects. Many patients get constipated. Again, as I said, we don't have many prescription medications to increase appetite. One that we do prescribe a lot actually increases appetite and weight, but it's mainly water weight and not lean body mass. Pain, I've done a number of studies, protocols in patients with both pain from nerve damage as well as pain on chronic opiates. And what we found in our chronic opiate study, which was really a pharmacokinetic interaction study to see what happens to the blood levels of morphine or oxycodone when patients inhale vaporized cannabis along with their opiates. And we found that there was no real change in the level of the opiates in the bloodstream, but what we did see was that patients achieved some greater relief of their pain when the cannabis was added to the chronic long-acting opiates. So this would suggest that people could perhaps lower the dose of their morphine or oxycodone and be able to stay on a lower dose for a longer time when it's given in addition to cannabis. Sleep. Many patients have difficulty sleeping with cancer or without cancer. There are different blends of cannabis. The cannabis sativa seems to be more stimulating, where cannabis indica seems to be more sedating. High THC variants of the medicine seem to be also a little more stimulating, where high CBD or cannabidiol-containing strains are more sedating. I have patients who swear by high CBD cannabis to help them sleep. And many of the short-acting benzodiazepines that physicians prescribe for sleep are really quite habituating and addictive and associated with a lot more side effects than cannabis. This is a very safe medicine, despite what the government tells us in their drug war propaganda. I was very excited to see that Sanjay Gupta has now decided that we've been duped by the government and that cannabis is good medicine. So again, decreasing sleep medicines and depression. I mean, it's all going to come down, as everything else does, to our genes and the field of pharmacogenomics, how different people respond to different medicine based on their genes. And we now know that we all probably have different cannabinoid receptors that may be slightly different by one amino acid or another to other people, which might make them act differently. So some people, when they're exposed to cannabis, feel nothing. Some people get very elated, and some people might get paranoid and a little depressed. But for those people who get some elation or euphoria, which we consider to be a negative thing, I mean, if you're dealing with a terminal patient, I don't think euphoria is an adverse experience. I think it's a good side effect. And I think cannabis is more useful than some of the antidepressants, which my patients tell me just basically numb their feelings and make them no longer care about anything. So, I mean, we can replace a lot of prescription medications with cannabis if the patient is having a good responses.
Well, Dr. Donald Abrams, I want to thank you so much, sir, for joining us today. Your information is priceless, and I look forward to working with you in the future, sir. Thank you again.
Thanks a lot, Al. Pleasure to talk to you.
My next guest on this program, this really a historic program, is Dr. Raphael Mechoulam. I have nicknamed Dr. Mechoulam the grandfather of medical cannabis, but indeed he is. Back in 1964, it was Dr. Mechoulam and his colleagues that isolated THC in the cannabis plant, and that has led to the astonishing science over the last 50 years that has led us to a discussion that we just had with Dr. Abrams and a discussion we're about to have with Dr. Mechoulam about the endocannabinoid system. Dr. Mechoulam, welcome, sir.
You're welcome. Can you hear me? Can you hear me?
Oh, yes, sir. Very clearly. Very clearly. I would like you, please, to tell the folks a little about your background and your lab and explain to the people the significance of the endocannabinoid system, doctor, if you would.
Well, I'm a professor of chemistry, medicinal chemistry. I've been studying cannabis for exactly 50 years. I was a very young man when I looked at projects which were of interest, and I was surprised to a large extent to see that while morphine had been isolated from opium early 19th century and cocaine was known again 100 years previously, the active constituent of marijuana, of hashish, had never been isolated, had never been identified, really. That seems strange. So I got some hashish from the police through the Ministry of Health here, and we looked at that, and we were able to isolate and elucidate the structure of the active constituent. We didn't know which one of them is the active constituent, so we had all the compounds tested on monkeys, and we isolated about 10 compounds, the major ones that are present in cannabis, and we found that only one of them, the THC, caused what we would probably say it's the same thing that happens in humans, happens in monkeys, and that was the only psychoactive compound. So that was 1964, and we also identified cannabidiol, which had no psychoactivity but had caused all kinds of other effects. And for the next 10, 15 years, 20 years, people looked at THC, looked at cannabidiol, looked at what happens in the body, looked at what these compounds do. But surprisingly, it was not known how they do that. Then my group and additional groups started looking for some details. And yes, we thought that there should be a specific biological thing, whether it's an enzyme, whether it's some receptive site or something in the body that THC stimulates. And indeed, Aline Howlett, she was a very young researcher at that time. Aline Howlett and her group found that there is a receptor in the brain. Then a second group in the UK found that there is a second receptor. They were different. And so we then knew that THC acts on a receptor and does whatever it does through a biological entity. Now, these receptors are not found in the brain because there is a plant out there. It doesn't work that way. There should be compounds which we produce, our brain produces, and these activate those receptors. So we started looking for the compounds, our own compounds, the endogenous compounds, which will activate these receptors. And about 15, 20 years ago, we were able to identify very small amounts produced by the brain of two compounds. One, the first one we called anandamide. Ananda is, we were very happy to have it. Ananda in Sanskrit is joy, happiness. We thought that it may be involved, but maybe we called it that because we were happy to complete that research after so many years. And my colleagues and I called it indeed anandamide. Then a second compound, which has a very long name, but the short name is 2AG. These two compounds are formed in our body, both in the brain and in the periphery. They activate these receptors, and THC actually mimics their action. There has been a huge amount of work on these two compounds, on the whole endocannabinoid system, if you wish. These are the receptors, and these are the compounds found in the body that activate them. There are the mechanisms that the body uses to amplify or to block these actions, and all this represents the endocannabinoid system. Would you like me to go on or describe some of the work that has been done both with the cannabinoids and the endogenous cannabinoids or endocannabinoids? Can you hear me?
I would like you to go on, but yes, I can. I would like you to go on, Doctor. There will be a slight delay between our times here. But if you could just tell the folks listening, we've gotten to the endocannabinoid system. What does this mean for them? The person in the street, the lady that lives in Australia, what's it mean for them?
Well, we know, and we had studied the activities of THC and of cannabidiol previously quite extensively. And we realized that they, as I said, they mimic the activity of these endogenous cannabinoids. Unfortunately, we always believe that the medicine goes ahead. Well, fast, and we are much better than, let's say, in the 20s. Well, this is not exactly true. When insulin was discovered in the early 20s, within 6 months, it was used as a drug. When the steroids, the corticosteroids, were discovered in the late 30s, early 40s, within a year or two, they were used as anti-inflammatory agents and then as many, many other types of drugs. Well, anandamide and 2-AG, although they are present in the brain, they're present in our body, they do a lot of things, and they have never been administered to a human, at least not legally. Why? Because in order to put a compound like that in the body, one has to look at the toxicity. Well, these compounds are not toxic, but in order to do a very wide range toxicity, one needs a lot of money, and nobody has spent that kind of money. So we do not know what anandamide and 2-AG do when we introduce them into the body. We can give THC under certain conditions, and we have done that many times. We have used anandamide and 2-AG to look at diseases of mice and rats and other animals, but we have never given anandamide to a human. We have given THC. As a matter of fact, we gave THC about 25 years ago, or maybe it was 20 years ago, to a group of children who were undergoing cancer chemotherapy. And we gave THC under the tongue, 5 milligrams pure THC, prepared in my lab, and all these children stopped vomiting. We published that. We gave it 400 times, and 400 times the effect was absolute, 100 times absolute. We gave the other compound, cannabidiol, to patients that had epilepsy. This was done with colleagues in South America. And yes, we had absolute activity in these very difficult epilepsy patients. This has gone on and on. Very recently, a group in Germany did a very, very exciting work with cannabidiol, very large doses of cannabidiol, about 800 milligrams a day. They gave it to schizophrenia patients, and they compared these patients with patients that were getting one of the standard antipsychotic drugs. Now, both groups, in both groups, one could see positive effects, and both groups were essentially the same. The compounds worked. Both cannabidiol worked, and the known antipsychotic drug worked. But, and that was a big difference, cannabidiol did not cause any side effects. The antipsychotic drug, which is widely used, is known to cause side effects, and it did cause side effects. So here we have anti-schizophrenic drug. Hopefully it will be used, but I doubt it because there is no patent. No company will try to put it on the market. Here we have a compound at high doses, very high doses, it works in schizophrenia. Probably the same is true for anxiety. Now, I wish we could test anandamide and 2-AG in patients. We have done, and we and many, many others have done a lot of work on mice and a lot of other animals in a variety of diseases. And here we have a very promising drug which has never been evaluated. But let me go into a little bit deeper. The receptors, there are two receptors, the endocannabinoid receptors. One is called the CB1 and the other is the CB2. Stimulation of the CB1 receptor causes the high. It also causes a lot of positive effects, but it causes the high, and therefore probably most pharmaceutical companies will not be interested in the CB1 receptor. By contrast, the CB2 receptor does a huge number of very positive things, and it does not cause the psychoactivity, which the pharmaceutical companies would very much like. So there are a lot of compounds that are being prepared today that act specifically on the CB2 receptor, and it acts on a huge number of diseases, at least in animals. Now, these compounds act on so many diseases, it becomes a little bit strange. How come that stimulation of one receptor will cause so many things? Well, it is quite possible that it is a general protective agent, a general protective system, and it acts on basically on inflammation. When one stimulates the CB2 receptor, one gets an anti-inflammatory effect. And one can see that in heart diseases, ischemia of the heart. One sees that in stroke. One can see that in inflammatory bowel diseases, in Crohn's disease, a lot of diseases that are based on inflammation. We have done, in collaboration with Spanish colleagues, work on Alzheimer. We found that if we cause an Alzheimer type disease in mice, we can lower the effects by administering cannabidiol. Other groups in other animal models have shown that again and again. So here we have a type of compound that may act on a huge number of diseases. Can you hear me? Hello?
Yes, we hear you.
Yes, sir.
Okay.
Could you tell us, Doctor? First of all, I should identify for the folks listening that Dr. Mechoulam is the Lionel Jacobson Professor of Medical Chemistry at Hebrew University in Jerusalem. And he also runs an incredible research lab. Doctor, what is your lab working on right now? What are your more goals that you're looking for to accomplishing?
Well, you see, anandamide and 2-AG are two important compounds, but our brain, for some strange reasons of which we're not fully aware today, makes about 200 to 300 related compounds. We know very little about their activity. We're looking into the activity of some of these compounds, which are related to the cannabinoid system. They may not directly activate these receptors, but they're somehow related because we can block their activity by blocking the endocannabinoid system. So they're related somehow. And let me give you one example. Nothing that has to do with the brain, but actually has to do with osteoporosis, our bones. There are statistics showing that in the Middle East, around the Mediterranean, there is 50% less osteoporosis in women than in Northern Europe. And possibly that was due to olive oil. So we looked at olive oil, we looked at the constituents, nothing major. Then we decided maybe the body converts that constituent of olive oil or lake acid, converts it into something which is closely related to anandamide, the endogenous cannabinoid. So we looked for that kind of compound in bones, and lo and behold, we found that. We found a compound which is closely related to anandamide, to the endocannabinoid system, and which is a very potent anti-osteoporotic compound. We synthesized it, and we tested that in animals that we caused in them osteoporosis, and it is extremely potent. Now, this compound, oleucirine, I hope that somebody will develop it. Now, this same compound is present in the brain. We haven't got a focused idea what it does in the brain. There are other compounds. There is another closely related compound which is present in the brain. When we identified it, synthesized it, we gave it to animals, and it causes, it affects their blood vessels. It opens them up. And so we started looking at that, and we found that this particular compound, when given to animals after brain damage, after trauma, lowers the effects of the trauma. So here we have something, I believe, very promising, and there are about 200 to 300 compounds there waiting to be investigated. Quite a few other groups are looking into those compounds. Chances are that these compounds, many of them represent the natural, or one of the natural ways of fighting disease, or if we go even further, maybe these 200-300 compounds also determine many of determine our behavior as human beings. If I can speculate for a second, we are all different. Each one of us has a different personality. We haven't got a focused idea why each one of us has it has a different personality. Is it possible, just possible, a speculation, that it has to do with the equilibrium of these 200-300 compounds, which may cause these differences? So we are going into psychology. We published that in a psychology journal, and we said it's a speculation. And the editor said, no, it's fine. It makes some sense. So chances are the endocannabinoid system is not just something that our body has to fight disease, which is extremely important, of course, but it also has to many other effects, or it influences our behavior. Well, this will be for the next 50 years. As I said, we've been working now exactly 50 years on the cannabinoid system. I hope that in the next 50 years, people will find out a little bit more.
Well, Doctor, thank you so much for joining us today. It was a remarkable lecture you just gave. My best to you, sir. I hope we meet again soon.
Be my guest. Bye-bye.
Dr. Mechoulam is the world leader in this issue of medical cannabis, and as you can tell, I think he's quite disappointed that we seem to be going into this discussion of medical cannabis as political science instead of real science. And you could tell if Dr. Mechoulam and others could get the real science as being the benchmark that we work with instead of political science, I think all of us listening all over the world would be a lot better off. My next guest is from Europe, from Germany in particular. Dr. Grotenhermen is a medical doctor, and what I would like him to tell us about is, of course, his personal experiences with cannabis medically and his founding of the IACM, which is a organization remarkably similar to Patients Out of Time in that we deal with the medical cannabis issue only, and we do it on a science-based level. Doctor, good day, sir.
Hi, Al. Good to talk to you.
Thank you for being here with us. If you could jump right in, I know you've listened to Dr. Mechoulam. if you could jump right in on your ICAM and focus, if you can, on the CBD system and the ECS system and what your European colleagues are thinking about this science, I'd appreciate it, sir.
Okay, very good. Well, I started to get involved in the issue of cannabis and cannabinoids as medicine about 20 years ago. And I noticed that in Europe there is not much knowledge on this issue. And with some friends, I decided to form a group, the German Association for Cannabis Medicine. This was in 1997. And North America and Canada were much ahead of Europe concerning this issue. And then some friends from outside Germany, for example, from the UK, Roger Pertwee, or from Spain, and they asked, why don't we make this organization, the Association for Cannabis Medicine, international? And we decided to form a scientific group, an international group, which is the ICM, which was formerly called International Association for Cannabis Medicine, which was founded in 2000. The main thing was that most people were working very locally or nationally, and we found it very important to have an international exchange, not only on the scientific level, but also on the political level, and to bring people together. And so we formed this group, and the main reasons were to promote exchange of information between researchers, healthcare practitioners, patients, and the public, and to disseminate reliable information on the pharmacology, toxicology, and therapeutic potential of cannabis and cannabinoids. And we find it necessary to have a place where this is happening, and people can go to the website and get a regular newsletter to get information on all relevant issues concerning scientific issues, concerning political developments, and related issues. So this was the start and main reason for forming the ICM. And it's still very important. Many people are thinking on this issue on a national basis, but we need a global view on it. What is happening in Europe? What is happening in North America? What is happening in Latin America? What is happening in Africa? And we try to work together and exchange information.
Are you trying to become the global umbrella, Franjo? I mean, I think your group would be well suited to do that. Is that one of the goals of your group?
I'm also very active nationally in Germany as the head of the German Association for Cannabis Medicine. But I was also always interested in having a broader view to other countries, what is happening there, and to bring scientists together. For example, we have meetings every 2 years, the next in end of September in Cologne, the conference on cannabinoids of the ICM. And this is one of my main focuses, to bring people together and to spread the information. For example, our ICM bulletin is available in 6 languages, so not only in German or not only in English, but in Spanish and Italian and other languages. And reliable information is very important to get people involved, to get people think about it. What is the value of cannabis? What is the function of the endocannabinoid system? Because the politics is also always influenced by prejudices and not always by knowledge. And this is what we want to try to change, to bring the knowledge, to allow people to get the knowledge and to get reliable knowledge on the issue.
Yes, be sure and tell us your address, your email address, and your webpage for the IACM before you go. But we here in the United States know very little about what is going on with cannabis research in Europe. Could you give us a lowdown on Germany in particular, and then your best speculations about some of these other countries that may be leading the way here that we don't hear much about?
Well, I can give you some examples. For example, today there is no major university in Europe where there is not scientific research on the endocannabinoid system or cannabis or cannabinoids. It's mostly basic research. For example, in Spain, there is Dr. Manuel Guzman, who is the leader of cannabis and cancer. Not the side effects of cancer chemotherapy, but how THC and cannabinoids can cure cancer, perhaps. And we have, for example, the group of Roger Pertwee in the UK is also a very leading group in endocannabinoid research. And we have also some groups in Germany who are, for example, at the Max Planck Institute, who researched on the endocannabinoid system and anxiety or post-traumatic stress disorder. So we have in Europe many centers which are leading in some of these special issues. And of course, there's always an international cooperation on these issues. As, for example, as Raphael Mechoulam told us, to elucidate the function of the endocannabinoid system, it's always an international process. And so there are groups from Spain, UK, Germany, Israel, USA, Canada, working together on these issues.
How about your university system? Is specifically your doctors, your medical schools in Europe, the nursing schools in Europe, are the doctors and nurses now taught about therapeutic clinical uses of cannabis? Are they taught about the endocannabinoid system?
The knowledge is today quite limited. The situation for patients is very different in different European countries. For example, the Netherlands or Spain have a situation where it is very easy for patients to get contact or to get cannabis to treat their symptoms. Whereas, for example, in Greece or in France or in Sweden, it's very, very difficult. People may get an exemption to get Marinol, and they will never get an exemption to get cannabis. So this is very different in different countries. And similarly is the situation for the knowledge of the doctors. Germany is somewhat in between. Last year we managed to publish, I together with Kirsten Müller-Wahl from the University of Hanover, to publish an article in the German Medical Association journal on the medical use of cannabis and cannabinoids, and we had to work for 10 years to publish it and to bring it to every doctor. But many doctors are still very reluctant. And for example, in Germany, we have the situation that doctors can prescribe dronabinol, they can prescribe Sativex, they can prescribe Nabilone, but there are only about 4,000 or 5,000 patients in whole Germany who get access to these medications because they have to pay it on their own and they are rather expensive. And a few years ago, the government agreed, okay, we'll make up a program to allow patients some access to cannabis and to get an exemption for the use of cannabis if no other medication works. And currently there are only about 200 patients in this program. And the main problem for the patients is to find a doctor who says, yes, this patient needs cannabis because all other medications do not work. And I am ill for about 23 years and lying in bed, and I do not practice for a long time. But 1 year ago, I decided, well, I will open a medical practice so that people can come to me and who don't find doctors. And I get patients from all around Germany because it's very difficult for many of them to find a local doctor who supports them. And the situation is much easier in Spain, for example, or in the Netherlands, and much more difficult in Greece or Bulgaria or Norway or France, where it's even more complex and more difficult.
Yeah, it sounds sort of like in the United States, where you go to some state over here, Franjo, like California or New Mexico, they have a very good program in effect, and they'll treat all sorts of symptoms. In fact, in California, there's no list or limit. But you go to another state like, these Confederate states, all these old Confederate states in the Southeast, and they got their heels dug in, and they're not going to let their people have cannabis to help them no matter what. It's a strange, baffling situation to hear that it's the same in Germany. Could you give the folks, we've got a few more minutes here, Patients Out of Time and the IACM and a number of other organizations are working on a declaration. I wonder if you could give that some time, explain to the audience what this declaration is about and what brought it on, if you would.
Yes. What we see today is that we have some countries, for example, Canada or the Netherlands or Israel and many states in the United States, where it is very easy for doctors to prescribe cannabis, or patients have at least access to some kind of cannabis. And we see other states and countries where it is very difficult. And people can, for example, in some countries in the world, you can get 5 years or 10 years in prison for the medical use of cannabis, and this is not okay. And we thought 1 year ago, we started to think, this is a medical right, this is a human right that people get access to a treatment with cannabis and cannabis if they need it, if it helps them, and it is the right of doctors to prescribe them cannabis or cannabinoids, or to open them a way to a treatment with this. And this is a global issue. We have now about 20 or 30 countries where people have some access to cannabis or cannabinoids, and the rest of 160 or 170 countries, there is no such program or no access or no legal access. And we thought it is time for a declaration that it is a human right for patients to get access, to have access, and a right for doctors to help their patients with cannabis if they are in need. And that was the basis for us to contact organizations such as Patients Out of Time or Americans for Safe Access, or organizations in other countries, in Norway or Italy or Spain or France or Switzerland and Austria, and single people such as Raphael Mechoulam or Roger Petro or William Naukat or Donald Abrams, or people and groups who might support a declaration that says this is a human right, and to create awareness of this right, which is denied in many countries today. This is not the current scientific status that cannabis is denied to people today.
Well, of course, I'm part of that program, as is the entire organization, Patients Out of Time. We feel that if one patient is allowed to use cannabis, it's the right, therefore, of all patients everywhere, every citizen of the world, to have access to cannabis. I mean, our own federal government, as you know, Franjo, has 4 patients. They're all part of the board of directors of patients at a time that get federal cannabis issued to them from the pot farm in Mississippi every day of their lives. Yet the rest of us, on a federal level, are considered criminals for using the same medicine that these 4 use. So
Yeah.
I applaud your effort. I'm glad it came from Europe. I want the folks here to understand that in the United States that there is a European community out there that feels the same way about medical cannabis as we all do on this program. Could you make sure you give us your web address, please, and tell us just a little bit more about your next conference before we have to go?
Okay, our website is www.cannabis-med.org, International Association for Cannabinoid Medicines. Science in cannabis is advancing very quickly. Raphael Mechoulam just told you what he's doing currently. We see every year remarkable new advances, and for example, 10 years ago, nobody talked about cannabis and post-traumatic stress disorder or other psychological disorders. It was only somatic diseases such as pain or nausea or appetite loss. And today we look at hyperactivity, post-traumatic stress disorder, even schizophrenia. Some patients profit from it, or other psychological disorders. And so we feel the need that we meet every 2 years and exchange the new information. We have several parts. There are also patients who tell the audience about the experience. There are physicians who tell the audience about the experience. There are scientists who talk about their experience. And there are also representatives of the pharmaceutical companies who tell about their experience. And we want to bring the people together and exchange the new information, what they need, and there's much beyond the program, the official program. There's much of informal talks. Bringing people together always means that we sit there at a dinner and now what are you doing in your lab, and there are patients talking to scientists and exchange. This is very important. So we meet again in September to get an update of the current situation for scientists, researchers, doctors, patients.
And I hope you get some government people there, some politicians that will listen to what is going on. I'd like to call, before we let you go, Doctor, I'd like to call the audience to get to the attention of 2 great books, both by Dr. Grotenhermen and a co-author, Dr. Ethan Russo, a U.S. author. But they are the Handbook of Cannabis Therapeutics from Bench to Bedside, and Cannabis and Cannabinoids, Pharmacology, Toxicology, and its Therapeutic Potential. You can find them on Amazon, guys. Doctor, thank you very much, sir, for being with us today. We much appreciate it.
Well, nice to meet you.
I like to jump in here for just a minute and make it a point to say thank you to AmericanFreedomRadio.com for allowing us to do this 2-hour uninterrupted commercial-free presentation on medical marijuana and, of course, the need to end prohibition. This is the first hour of 2 hours on that topic and the second of 5 conferences being held.
Look at our